Everyone hear me okay? Welcome
Yeah.
to ALiEM Connect. This is amazing. I think we were just doing a little early troubleshooting, and this is our first ever launch of a live telecast paired with a concurrent Slack back channel discussion. This is blowing my mind that this is going live. This initiative arose quickly, really after 10 days of planning. It came about in response to how all the programs, residency programs had to abruptly shift and change their educational experience for the residents because of this unfortunate COVID-19 physical distancing era. And so we on the ALiEM team felt like, hey, we need to chip in and work in solidarity to work with all these our fellow educators during this unprecedented upheaval time. So when we planned this, tons of people came out of the woodwork, and I got to give them a shout out to help with let's build something new to address this. And we didn't know what that looked like until Dr. Christian Rose came into the picture. Woo! And he is a clinical informatics fellow at Stanford and came along and brought this whole team together, brought the vision together, and brought all of our partners together. And hence the birth of ALiEM Connect, and 10 days old now today. Since then, we have garnered the exclusive support of the American Board of Emergency Medicine. Woo! And this is the cool part. They're in the Slack channel, also on their own channel called ABEM, and they're here to answer any COVID-related credentialing issues and questions you might have, such as, what if I get quarantined? Can I still be ABEM certified? So check out that channel, ask them questions. Also, thanks to Slack, Zoom, Coursera, all those people who came out to rescue with this rapid launch of the event. So who's on the rest of the team? There are tons of people, but three I got to give a shout out to, and they are the moderators, and they're going to engage with you, the residents, and asking questions of the speakers. And that includes Dr. Sarah Mott, who's waving, hopefully you could see. She's a community emergency physician in Minnesota, but more importantly, our chief logistics officer of the Wellness Think Tank. We also have Dr. L.A. Alvarez, who's the assistant program director, wave high, at Stanford. And we have Dr. Tim Moncrief, who is a stellar chief resident at the University of Miami. So keep a lookout for them in the Slack channel, and they'll engage with you and figure out how to get some questions up on Slack. So here are the rules of the Connect event. If you are an emergency medicine resident seeking 2 hours of conference credit, one, go ahead and sign up on the Connect page. It's just a quick drop-down menu and put your initials in your year of graduation. All of your program administrators have access to the Slack or to the Google spreadsheet. Second, join the Slack account and then manually add yourself to your program's individual Slack channel so you could have your own small group chat. Three, go ahead and just ask questions of speakers on their topics in the appropriately named channels. It's got their last names on there. And if you see a question that you know the answer to, go ahead and just answer them. This is meant to be a safe community of practice where we can engage with each other. Think of it as going to conference, but like with another 1,000 residents. It's a small group, no problem. Just go ahead and engage as much as you can. And then if you have similar questions as those that you see already posted, we're going to try to minimize any clutter on Slack. And so if you have the same question, just put a little thumbs up emoji and we'll track these numbers. And if they're really popular questions, we'll lob it back up to the speakers. So that's the theory. That's the plan for this 2-hour event. And let's just launch right in right now, unless any of the speakers or the moderators have anything to add. No, they do not. Perfect, because I muted them all. Let's go ahead and launch right into the first channel. And by the way, all our speakers are educational giants in our field. You don't realize how big they are, but they're ginormous. And so we're extremely grateful that they're coming to donate their time while balancing all of their duties during the COVID era. And so they're, frankly, in my mind, superheroes. And in that vein, I wanted to actually assign them a superhero name from the Marvel world, but frankly, it doesn't do them enough justice in my mind. So what I did was I ran their names through this superhero name generator. And so it is with great pleasure that I introduce to you the very first speaker of ALiEM Connect, the Emerald Prism, Dr. Susan Wilcox, who is the Chief of Critical Care in the Department of Emergency Medicine at Massachusetts General. And she's actually on a string of nights right now. We're so extremely grateful for her being here. And she's going to hop off hopefully after the talk. And she's here to talk about severe hypoxemic respiratory failure in the time of COVID-19. Go for it, Emerald Prism.
All right, thank you. All right, so get up and running here. All right. Okay, so I'm going to be talking about management of severe hypoxemia in the time of COVID. So this is a little bit of an adjustment to the talk that I often give. And when I am talking about severe hypoxemia. I'm not talking about that patient who comes into the ED, they have to get intubated, you set them on the ventilator, they settle out and everything's fine. I'm talking about this kind of patient, the patient who comes in and you do all the right things, and despite that, they continue to get worse and you just can't get them to settle out. You can see why this patient is so hypoxemic. But what's going on with our COVID patients is very different. The patients are coming in and they are very hypoxemic. They have a high respiratory rate, but they're still talking to you. And it's a little bit of a different presentation, not what we're usually used to when we see patients who have a chest x-ray looking like that. This is an example of a patient I saw. The first chest x-ray is the one that he had in the emergency department. At that time, he had an oxygen requirement of like 4 to 5 liters, so significant. And if you look at the chest x-ray, it doesn't really look commensurate with that level of oxygen requirement. But then over the next 36 hours, unfortunately, he deteriorated, and you can see the development of his infiltrates on the chest x-ray, and he ended up getting intubated with his COVID-19, very unfortunately. So these patients come into the emergency department and they'll be sitting upright. They are using their accessory muscles to maintain their negative inspiratory force. And in doing so, they're keeping themselves recruited. So we determine that they need to be intubated. And the next thing that we do is we give them sedation and then we lie them flat or nearly flat. And so what happens is they have buggy, let me see. Oh, okay. Sorry, I guess it seemed like it wasn't actually sharing. I apologize. It looked like it was. So, all right. So the patient comes in and they have this dense, wet, boggy lungs, and we lie them flat. And then what happens is they de-recruit there. They lose all of that recruitment that they had been maintaining. And this isn't just something that I have on a cartoon. I've got some illustrations here that will show the de-recruitment. So this is a CT scan right there. You can see that it's not just a conceptual model. And then here we have the heart showing how it compresses. And these patients are so fragile, even that level of compression from the heart can lead to a significant de-recruitment. So the first thing that we can do in the emergency department is to try to re-recruit them with a PEEP valve. And the first important point about this is that if you're ventilating these patients who have COVID-19, you really want to make sure that you've got the HEPA filter in between the patient, the endotracheal tube, and your bag. It's absolutely critical. You cannot ventilate them without having the HEPA filter in place. The other thing to do is put the PEEP valve on. The PEEP valve is an adjustable device that allows you to give PEEP between about 5 centimeters of water and 20 centimeters of water to re-recruit that patient who de-recruited when you intubated them. When you put them on the ventilator, I could give a whole talk about this, and I do, but the key points here about putting these patients on the ventilator is that you want to have low tidal volume ventilation. It's so critical to start with 6 cc's per kilo, and that's not their total body weight, that is their predicted body weight, which is based upon their height and their biological sex. The next thing that we do is check their pressures on the ventilator. We want to have a low tidal volume, low pressure ventilation strategy. The pressure that we care about most is the plateau pressure. The plateau pressure is what you get when you do an inspiratory hold. Stop all flow within the system and see where the pressure settles out. The plateau pressure should be less than 30 centimeters of water. It's absolutely essential. Next, we'll optimize their PEEP. We usually start with about 5 of PEEP for most patients, and that's fine for many of them. The patients with COVID-19 are coming in and they're pretty recruitable. They have a lot of that de-recruitment. So we need to use a higher PEEP in many instances to re-recruit them and open them back up. And so it's not uncommon for these patients to need greater than 8, like into the 12, 14, even up to 20 centimeters of water pressure for the PEEP. And then it might seem counterintuitive to think about decreasing the FiO2 in severe hypoxemic respiratory failure, but it is also essential to try to get that FiO2 down if you can at all. The FiO2 has been shown to correlate with few moments, 5 minutes and 20 minutes. You can see that they get boggy, edematous, and hemorrhagic. And the mechanism here is shown in the electron microscopy. Using these large tidal volumes actually shreds the lungs. and that leads to cytokine release, multi-organ system failure, and downstream effects. So they might look okay in the ED, but then when they get up to the ICU, they're having all this cytokine release, and then later on, days to weeks later, we see the results. Once you have the patient optimized on the ventilator, you want to make sure that they're synchronous with the vent settings that you have. And we used to give patients neuromuscular blockade, cisatracurium, pretty regularly when they were in ARDS. There was a study that was released just last year, but in May of 2019, that showed that it's actually not essential anymore to give these patients neuromuscular blockade. They've randomized about 1,000 patients with ARDS to early neuromuscular blockade or not. And what they found is that there was really no difference in their outcomes. And so the takeaway from this is that it doesn't seem to cause harm. But if you have a patient who is having a lot of trouble being synchronous with the ventilator, despite optimizing their sedation regimen, go ahead and provide neuromuscular blockade. Again, once you know that they're well sedated, because we don't want them to sit there and pull and tug at the ventilator and cause that shredding that we saw in the electron microscopy. Another thing that we don't commonly do in the emergency department, but we will probably start doing more, is proning patients. It's really not that hard. We as emergency physicians are very comfortable rotating patients when they are intubated for like a trauma, if we want to look at their back. When we're proning a patient, it's really you just turn them and then you just keep on going. Thinking back to the D-recruitment I started with, this is why it's so helpful. So you have that big surface area on the posterior aspect of the lung. And then when they're de-recruiting, it's all along that surface area where gas exchange should be occurring. If we flip them over, you can imagine that all of that weight is now going to be on the front, which is a smaller surface area. The other advantage, as you can see in those CT scans, is that the heart is no longer compressing that posterior aspect of the lung, and it takes some of the weight off of the lung. And even that little bit can really be beneficial in these patients. So getting that weight off of the back of the lungs can be very helpful. And it's an evidence-based strategy. It has been shown to improve mortality with a hazard ratio of 0.39 in a pretty large multi-center study. So proning is an evidence-based way to improve mortality in patients with ARDS. Another thing that we can try is inhaled pulmonary vasodilators. I got to say, I really love these, but I have to acknowledge that inhaled pulmonary vasodilators don't actually have a mortality benefit. They can improve oxygenation though. What they do is they go to the good parts of the lung, and that leads to vasodilation, so improved VQ matching. And so if you need to get somebody to an ECMO center, you need to transfer them. If you have some bridge, an inhaled pulmonary vasodilator can be very helpful. A key thing to know, though, is that inhaled epoprostenol is kind of sticky, and so the respiratory therapists have to change the vent circuits when you're using inhaled EPO. So we're not using inhaled epoprostenol in COVID-19 patients. We use nitric oxide instead because we want to minimize the need to open up the vent circuits and possibly aerosolize the virus. And then, of course, ECMO. Oh, ECMO. So, ECMO should really be considered for these patients. There was a big study that was published a couple of years ago looking at ECMO patients, the largest randomized control trial, and unfortunately, it was stopped for futility. A lot of authors refer to this as being a Rorschach test for how people feel about ECMO. The thing was that it was stopped for futility, but they had a very ambitious goal. They wanted to see a 20% difference in mortality, which would be hard to achieve. And the patients who were randomized to control, just all those normal good principles of care that I was mentioning before, about a quarter of them ended up getting ECMO anyway. And so a lot of people who are ECMO advocates, like myself, admittedly, say, there's still a place for ECMO with taking care of these patients. The important thing for you to know is what are your local protocols? What are your local guidelines? If you are not at an ECMO center, where is the nearest ECMO center? Can you transfer the patient there? And how are you going to get them there safely? These are things that we need to be thinking about prospectively as we're having more and more patients coming in with severe respiratory failure. So that was a super quick run through of management of hypoxemic respiratory failure. I fully acknowledge. But the key points I wanted to hit are de-recruitment is the enemy here. We have to re-recruit these patients. A PEEP valve is a great way to do it until we get the patient onto the ventilator. For ARDS, and many patients without ARDS, there are some just key principles of ventilating them. Low tidal volumes, 6 cc's per kilo of their predicted body weight, plateau pressures, keeping them low, less than 30, increasing the PEEP, trying to get it optimized, and then minimizing the FiO2 whenever you can. Neuromuscular blockade is really helpful if the patient is desynchronous. Consider proning. I know it's not a typical emergency medicine thing to do, but there's no reason why we can't do it safely when we get everyone involved. And then pulmonary vasodilators can be a useful bridge, but not inhaled epoprostenol just because of the need for the circuit changes. And then if you're doing all of these things and you're not getting progress, you should strongly consider ECMO. At that, go ahead and stop sharing here.
That's amazing, Susan. I just wanted to say thanks for sharing those. Those are really practical pearls. I wanted to add just a little bit of a technical detail here. You guys broke the internet, and so that's why our Connect page is down. So that we just added all of the separate units. We put the YouTube link in the Slack channel under announcements. We also put in the sign-in form direct link also in announcements. So feel free to take a look there. But yeah, y'all broke it. I'm going to hand this over to the moderator to see if we have some questions for Susan.
I think you're muted.
Sarah, any questions?
Yep, sorry. So one of the questions that came up was that what are your thoughts about inhaled glucocorticoids?
So what we are seeing in these patients and what we know from our influenza A patients is that glucocorticoids are associated with worse outcomes, definitely for the influenza A patients. And so there has been some extrapolation that it probably is not recommended for the majority of patients that are presenting with respiratory failure from COVID-19. Inhaled glucocorticoids would be, I really don't think that there's enough data yet. It's a good thought, and there's probably a subset of patients who have a hyperinflammatory response that might be responders for glucocorticoids. We just don't know exactly yet which patients those would be. So I would hold off on thinking about inhaled glucocorticoids at this point for the COVID-19 patients.
Perfect. And several questions came up regarding what is the preferred first-line sedation for these patients?
Oh, that's a great question. So I would say propofol. It's, our old standby, our good friend propofol. It works really well. It's a powerful respiratory suppressant. And if it's not getting there, if the patient's getting too hypotensive or you're getting up to pretty high doses, then the next thing to do would be to add on an opioid. Fentanyl is a great one. Fentanyl is, as we know, a great respiratory depressant. And so in this case, we can use it therapeutically as an adjunct with our propofol.
And do you notice any contraindications for paralytics in this case?
Oh, yeah, great question. So there doesn't seem to be any contraindications. I'm assuming that's talking about once the patient has already been intubated. The general recommendations are to treat them like any other ARDS patient. And for that purpose, we will give them neuromuscular blockade if they are desynchronous, if you're not feeling like you can get those nice smooth waveforms on the ventilator, because we know that synchrony really does shred those lungs, and we want to do everything we can to prevent that.
Any thoughts about the actual transport of these patients when they're in prone? Is there any safety precautions that we need to do extra?
Oh yeah, so this is an issue that comes up all the time in my life. I'm the Associate Chief Medical Officer of Boston MedFlight, so we have to think about this a lot. Traditionally, transporting these patients prone has been considered a no-no, and that's mostly talking about inter-facility transport. But you can imagine too that intra-facility transport, like from the emergency department to the ICU, you're going to be worried about pulling out tubes, lines, drains, and oh my gosh, extubating one of these patients is an absolute never event, both for the patient safety as well as the clinician safety. So it's something that you have to be very thoughtful about. It's not hard to prone, but you have to get buy-in from your nurse colleagues, your respiratory therapy colleagues, so that everyone is holding their tubes, lines, and drains and being very thoughtful as you're moving these patients either to prone them or to transport them.
Got it. Somebody asked about inhaled nitroglycerin. Any thoughts about that?
Oh yeah, so nitroglycerin's, as we know, a very powerful vasodilator, and it's a great thought. I know that there has been a lot of talk about this on some of the various excellent critical care and emergency medicine blogs. my take on it is that there might be a role for it now. I honestly just don't know how much it clogs up the vent circuit like inhaled epoprostenol does. Inhaled epoprostenol works very well. It increases the SpO2 in about 60% of patients who receive it. And so historically, my take has been, I don't know that it really offers a whole lot of advantage over inhaled EPO. But if it doesn't clog up the vent and it's cheap, it's easy, then in this situation, in COVID-19, we might be seeing a new role for it. I can't say that we officially do yet, but it is a good thought.
Yeah. What about APRV? Any thoughts about that?
So I'm just going to tell you up front, this is such a controversial topic in critical care. There are the APRV lovers and then the not lovers. I was raised by people who are anti-APRV, so I'm putting my biases out there right up front. That's the way I grew up in the critical care world. But what I will say is that it is an open lung strategy. We find that these patients are very recruitable, and so there may be some role. The concern is that sometimes in APRV, if somebody's not watching the ventilator very closely, they can start to get large tidal volume ventilations because the patients are allowed to basically do what they want. And we know how injurious that is. So if you're going to go for an APRV strategy, again, there might be a good rationale behind it. You just have to make sure you're watching that patient very closely because they can start to take large tidal volumes and you need to titrate down the pressure for those patients.
Got it. Somebody asked about CPAP with helmets. Are we seeing that? Do we have resources for that?
So again, it seems like it's a great idea. Anything that we can do to both take great care of our patients as well as protect our clinicians is essential during this. They have not been widely distributed. I know there are a few centers around the United States that have them. I'll just tell you, our center has been looking into getting them. And unfortunately, I think that they're being manufactured in Italy. And we know how our colleagues in Italy are being so impacted by this. And so we've had a lot of just pragmatic issues being able to get them. The other point that I would make is that, again, extrapolating from other studies of patients who've had different types of viral pneumonias, non-invasive has not been shown to work all that terribly well. The numbers that come to mind are about 60 to 85% of patients who were trialed on non-invasive with SARS, some influenza A, strain H1N1, ended up getting intubated anyway. And so there might be a subset, and as we're thinking about ventilator rationing, unfortunately, there might be a role for this, but just right now we don't have the practical ability to do so.
One last question. Apparently it's a very popular one. Ketamine. What are your thoughts about ketamine in these patients?
So I am a ketamine lover. That's another one of my biases. So I think ketamine is a fantastic drug. The one thing I would note is that ketamine has no respiratory suppression properties, or minimal, I should say. And that's one of the reasons that we love it. It's so great for so many uses for that. However, in the patient who is ventilated, you want to take good control, have a low pressure, low tidal volume, we have to be managing their ventilation. Having an agent that doesn't suppress the respiratory drive doesn't quite get us there. And so maybe it could be an adjunct, because I've also heard that these patients have been really difficult to sedate. So it might be an adjunctive agent. I just probably wouldn't use it as a primary one.
Again, thank you so much for your time, Dr. Wilcox, and we really appreciate your input here today.
Thank you so much for having me.
Yay. Also, Dr. Wilcox left a great, amazing resource on the Handouts Resources channel. It's a more comprehensive handout and information about what she talked about. So thanks so much for drafting that for us. All right. It looks like Emerald Prism is leaving the building. Moving on, we have next up speaker number 2. We have Dr. Salim Rezaie. He is an emergency physician of San Antonio Emergency Physicians Group, but you know him as the founder, creator, editor-in-chief of REBELEM, which is really setting the pace on, I know our mind is blown, he's here, he's real, who is setting the pace on keeping really current clinical information up on the interwebs for us to read. So thank you so much for joining us. He's going to give us a talk on walking the line from research to practice, and his superhero name I introduced to you, the Shining Mask. Welcome to ALiEM Connect.
Thank you so much for having me. Let me share my screen here. and hopefully everybody is seeing this.
It was so fancy.
All right, so we're going to talk about walking the line from research to practice. And the reason I wanted to do this is, at least when I was in residency, which is not that long ago, I never really felt like anybody taught me how to read these papers, how to break them down, understand the statistics, and then more importantly, how do I know when a paper is good enough to apply to practice? And so it really is kind of walking a line of research stats to bedside practice. I have two papers that I actually want to talk about today, and I've purposely kept it at two because I didn't want to overwhelm everybody with a bunch of stuff. And I picked two papers that have been published in the last 3 months that I personally found very interesting. And I think at least one of them is ready for prime time. The second one, maybe we need a little bit more evidence, but I still think they're both worth talking about. So the first one is the 65 trial. And this was a fascinating study to me that I feel like didn't get a ton of publicity, at least on a lot of the social media forums. And it's appropriately named the 65 trial, as you'll see why in just a second. But this was a randomized clinical trial of 2,600 patients that had vasodilatory hypotension. So I want to be specific about that. So that is not just septic shock patients, although 80% of the population was septic shock. So there was another 20% that had other causes of vasodilatory hypotension. So this is not a purely septic shock study. So why is the name 65 so appropriate? So this was performed in 65 ICUs in the United Kingdom. Almost makes you wonder when they came up with the name if they didn't want to start the study till they got 65 ICUs recruited. You could just see them at like 63 and 64. And then this was patients that were 65 years of age and older. And then the final thing is these patients got randomized to permissive hypotension, which they called a MAP of 60 to 65, or to usual care, which is what we all remember from early goal-directed therapy, which is targeting a MAP of 65 or greater. Now, what was fascinating about this in this older group of patients in the ICU is that when you actually break this down and you look at mortality at 90 days, which by the way is their primary outcome, there was no statistical difference in that outcome. A point that's worth making is that they looked at a bunch of patients in subgroups. And one of the subgroups they looked at is hypertension, which the evidence has been rather confusing for me. There have been a couple of papers that have been put out. Sepsis PAM was one of them that says that patients who have chronic hypertension probably need higher MAPs. And in this study, interestingly, when we look at that, and this is all hypothesis generating because it's a subgroup of a larger group, study's not powered for this, it looked like that people who have chronic hypertension targeting this lower MAP actually didn't hurt their overall 90-day mortality. So that's something worth mentioning. The next thing is that if you look at the time that these patients actually got vasopressors, well, it makes sense that if we're targeting a lower MAP, that we're going to be on vasopressors for less time. And so what we see is a 5-hour difference. And although that may not seem like very much, 5 hours or 6 hours less for a patient in the ICU or requiring vasopressors is kind of a big deal and adds up as we see more and more of these patients that are potentially hypotensive. The final thing is adverse events. So interestingly, there was no increase in acute kidney injury or any of the typical sorts of things we'd want to see, like multi-organ failure, allergic reactions, anything like that. There was no difference. So essentially, when you look at all their outcomes, there was no difference in mortality, no difference in adverse events, and patients were on the pressors for less time. Now, there's a few caveats that I really want to kind of emphasize here, and these are really, really important to understand. The first is this is a study of patients that are 65 years old and not younger patients. And the reason this is important is we have to be careful extrapolating this to younger patients. It may be that older patients just don't tolerate being on vasopressors as long, and maybe that doesn't extrapolate to younger patients. So we have to be really careful about that. The second thing I want to mention is you have to go through the methods of the study to understand exactly when this was performed. So what would happen is these patients would come to the emergency department, and in the emergency department, they would get their usual targeting a map of 65. Then they would get admitted to the ICU, and then they would be randomized. And at the point of randomization is when they actually changed the amount of vasopressor and the target they were going for. So this is usually within 6 hours. And the reason I mention this is because we don't know what this effect will be early on in a patient's resuscitation. Is having a lower map actually a good thing early on, or should we be still shooting for this 65? It's unclear to me based on this study. And so we have to be really careful. And the one thing to understand here is this is an ICU study, really. This is not an ED study. And the last reason that I mentioned this and the final caveat is you can imagine for nursing, targeting a tight map of 60 to 65 is going to be very labor intensive. And in the ICU, we see a nursing to patient ratio of 1 to 2. In the ED, this is oftentimes 1 to 4 or 1 to 5. Sometimes it's even 1 to 6, depending on how crazy it is in the department. And the reason I mention this is that what I can tell you for sure is targeting a map of 65 or larger probably has no effect on mortality in our patients. What's unclear is what happens when the map goes below 65 or 60. What happens if it hangs around 50 or hangs around 45? I would think that that is probably not a good thing for our patients. I would think that that is a marker of poor perfusion and probably is going to increase things like acute kidney injury and multi-organ failure. And so we have to be really, really careful about extrapolating this. So here's my bottom line for this study. Sepsis is really an interesting heterogeneous population of people. And although the guidelines tell us we should be shooting for this map of 65, the reality is that it kind of depends on your patient's protoplasm, it depends on their physiologic reserve, and it depends on where they're at on that spectrum of mild sepsis all the way to septic shock. And I suspect that what map we target is probably going to be needed to be individualized for those patients. But until we get further evidence to tell us what that number is for what subgroup, I think we should be going for 65. Now, the one thing I will tell you that this study has done for me is if I have a patient who's 65 and older and their map is hovering around 62 or 61 or 63, I'm probably going to be okay with that. I'm probably not going to start titrating my vasopressors up to try and get them to that map of 65 and greater. The final thing is that this is a study done in the ICU really and not the ED. And the one thing I want to add to that is that we should not use this study as an excuse to not admit patients to the ICU. These patients all still require ICU level of care, whether they're on that vasopressor or not. I think what this has done for me is it has made me more comfortable if I have a patient who's not quite at 65, which, to be fair, is what I'm already doing in practice anyways. This study just further supports that. The second study we're going to talk about is the PEG trial. And I found this to be a very, very fascinating study. And it's basically looking at clinical probability adjusted D-dimer. So what they did is they had patients that they brought in and they were evaluating them for venous thromboembolism. This was 2,000 patients, ballpark. And what they did is they used the Wells score to risk stratify patients. I like the fact that they used the Wells score because this is one of the best tools we have in terms of evaluation of patients for venous thromboembolism. It's one of the best studied. It's one of the best validated. It does not mean you can't use other risk scores, but this is the one that I find to be the most useful. And essentially with a traditional Wells score, we break people into low, moderate, and high risk. Now, what they did in this study is they said, well, if you're low risk, we're going to set your D-dimer threshold at 1,000. If you're moderate risk, we're going to leave it at 500, which is what we typically do. And if you're high risk, we're going straight to imaging. We're not going to even mess with D-dimers. And that's important because a negative D-dimer in a high-risk patient is going to have potentially false negative. So you're going to miss some venous thromboembolism if that's what you're depending on in the high-risk group. So let's get rid of the high risk group here just for a second. And let's focus on the low and moderate group. And their primary outcome in this study was venous thromboembolism at 90 days. And what was fascinating is they missed 0% of cases in both the low and moderate risk groups. Pretty impressive for increasing that threshold of negative up to 1,000 in that low risk group. The other thing that was very important is that if you looked at how we traditionally use a cutoff of 500 for our low risk patients, we would be scanning about 52% of people in this population. Using a PEG strategy drops that down to about 34%. So we have almost a 20% drop off in the amount of scans that we're doing, which is definitely a good thing. Now, just like every study, I like to talk about some of the caveats. And the first thing I would tell you is that this is a rather healthy population of patients. And the reason I tell you that is that if you look at the percentage of their 2,000 that fell into the high risk category, it was about 2%. If you look at the moderate risk, it was only 13%. So that means 85% of this population was in the low risk category. So essentially, this is a study of low risk patients. The second thing I want to say is that pregnant patients were excluded, and that's an important exclusion criteria to recall. Now, before I get to the bottom line, this isn't the first time we've talked about adjusted D-dimers. This is not the first study. This is not coming out from the blue. We have age-adjusted D-dimers, which have now several studies and been validated. We have the years protocol, which has 2 studies now. There's the years for the general population and then the years adapted for pregnancy. And now we have this. And so we have several studies now looking at this adjustment by probability or by age or in whatever area you want to look at. And it looks like it's panning out. And so for me, the bottom line is that risk-adjusted D-dimer, it reduces CT imaging, which I think is important, and in my opinion is ready for prime time. Now, before I conclude my thoughts on this, the one thing I want to state, and I want to be crystal clear about this, is that just because I'm telling you on ALiEM Connect that my opinion is this is ready for prime time, don't be a cowboy and start practicing this because this is where you heard it. This is a little more complicated than that. This needs to be discussed within your department. The group needs to decide that this is going to be standard practice. And this also probably needs to be discussed with your pulmonary colleagues and your hematology colleagues to ensure that everybody's on board. Because if you start practicing this way without ensuring that that is standard practice at your institution, you're putting yourself out on a limb. And if you miss a case or something bad happens, you don't have a leg to stand on. So although my opinion is this is ready for prime time, this is a bigger discussion that needs to happen within the institution before implementing it. So thank you so much, guys, for tuning in. I hope those 2 studies were helpful and you enjoyed the breakdown, and I am happy to take some questions.
All right, thank you so much, Salim. One of the questions came out is, can we generalize this to any of the vasodilatory shock?
So I think we have to be careful. So this was 2,600 patients and 80% of them were sepsis. So I would say by far and away, this was a septic shock population of patients that were 65 and older. You know, the number of other causes of vasodilatory shock were very minimal. And so that means our numbers overall were smaller. And so this is the first study that I have seen that kind of talks about this, at least in a randomized fashion. And just like anything else, you need to see validation before you can start implementing this in practice. So I would be a little cautious to say that this generalizes to all types of shock.
Got it. And what are your thoughts about, so people have been mentioning that maybe it's a lot difficult to measure blood pressure map when they're older. And so do you recommend central, like femoral line, A-line versus wrist, or is there a difference?
Yeah, so I got to tell you my practice, and this is my practice only, is that if I have a patient that I am putting on vasopressors of any kind, they're getting an arterial line. And that could be radial, it could be femoral, it just depends on the situation. But I think anytime you start somebody on vasopressors, whether you do that peripherally, you do it through a central line, you need minute to minute, second to second monitoring to ensure that you got tight control of whatever it is that you're doing. Otherwise, if you're just using blood pressure cuffs, you're going to underestimate, you're going to misrepresent that number. Most people will recycle that every 5 minutes. So what's happening in the 5 minutes between? And so my opinion is that if you're doing this, they need to have an A-line.
So what I heard was also there's no difference between wrist versus femoral lines in this case.
In this case, let me put it this way. So when people are in shock, they tend to clamp peripherally, and radial A-lines, although we do have ultrasound that can help, are more difficult, in my opinion, than femoral A-lines. So for my resuscitation purposes, for the initial monitoring, I do a completely sterile femoral line because it's an easier line for me to get.
That's a good point. You always have a lot of papers that you're reading. For our learners, there's over 1,000 viewers right now. How do you filter and read all of these papers? What is your approach?
I think the number one thing is having a good system of having the papers pushed to you. So I have created multiple avenues to have things pushed. So I use an app called Read by QXMD, and I've subscribed to the top 15 journals that I really seem to enjoy the most. And every time there's an online publication, I get the title and the abstract pushed to me. I have also created PubMed alerts where you can actually do the same thing, but you can pick more journals. And I'll send myself an email once a week of everything that's been published over the past week in those journals. And then the final thing is like, just pay attention on social media. I mean, anybody who's on social media will tell you that, there are so many great people out there that are putting out so much good content. And sometimes I will miss a paper that somebody else writes about. And that's a third way that you can have things pushed to you. So I think that's the key, is setting up multiple channels, having the info pushed. You scroll through the titles and the abstracts, you find what's interesting and what's not interesting. And then I got to tell you, like, let's say I find 20 papers that I find interesting. There might actually only be 3 of them that are worthwhile in terms of discussing or in terms of clinical practice.
Perfect. Thank you. I think we're moving on to the next speaker.
Perfect. Thanks so much for doing this, Salim. And thanks for sticking around. If you're willing to stick around, or feel free to leave.
I will be here the whole time.
You can't even get rid of you. Like, we'll all be gone. You'll still be here.
I'll still be here after this is over.
Oh, wow. No, but in all honesty, Salim is part of my personal learning network as well, especially on Twitter. Like, if he mentions it, you should probably pay attention to it. At least read it on your own and make your own decisions. It's worth paying attention to. But the more times you see this repetition of papers coming up, then you're like, wow, it's really important to talk about maybe more with my community. So build some personal learning networks. This is the perfect time to start as a resident. All right, let's switch gears now. And we have now Dr. Michael Gisondi, my partner in crime for the EM Match Advice series. Thanks for doing this.
What's up, co-host?
No, this is he's the vice chair of education at Stanford. And he is talking about, well, I actually asked him, I was like, what do you want to talk about? He was like, jaundice. I'm like, well, what about jaundice? He was like, all of it, just jaundice. It's amazing. And so I personally can't wait to hear about this. And I picked his superhero name out of this bucket, and it actually is quite appropriate, which is Dr. Nucleus. It knew you were a doctor.
Yeah.
Dr. Nucleus, welcome to ALiEM Connect, and I hand it over to you.
That's what my branding is going to be next, Michelle. That's outstanding.
Imagine those logos and everything.
Oh my gosh. Well, thank you so much, Michelle, for having me, and to the whole ALiEM team. I'm going to tell you that you are my N95 with a surgical mask, a face shield, and double gloves. You've been my rock during a really hard time. And I do want to acknowledge first, before I take you on a magical mystery ride of jaundice, that this is a really tough time. I'm super proud of the Stanford residents. I know every resident who's watching right now has been working so diligently in an uncertain time where you feel scared and where you can be upset at times. So I want to share briefly a quick technique that I use to kind of calm myself in the emergency department's ambulance bay, which is where I usually go to have my moment during a shift. And that's box breathing. So box breathing is usually paired with meditation. I'm not a very good meditator. I'm just not, Michelle. But box breathing I find really helpful. So we're going to do 2 box breathings together. I want all the faculty to do this as well. So we're going to inhale on a count of 4 through our nose. We're going to hold our breath for a count of 4. We're going to exhale through our mouth for a 4 count. And then we're going to hold our breath again for a 4 count. All right, so everybody, I imagine 1,500 residents are sitting alone in their apartments right now. And stop what you're doing, stop cleaning your apartment, stop internet shopping, and let's take just a minute to center ourselves. So you're going to inhale through your nose, 1, 2, 3, 4. Hold it, 1, 2, 3, 4. Exhale through your mouth, 1, 2, 3, 4, and hold it, 1, 2, 3, 4. And do it again. I'll do it with you. Inhale. Hold it. Exhale. Hold it. All right, I hope that gives you a little technique to reduce anxiety during a very difficult time, and congratulations to all you guys for all you do. You're my superheroes. All right, so with that, I promised a magical mystery ride of jaundice, and I'm gonna tell you we're gonna do a couple of things here. We're gonna talk about jaundice deeply. What does it mean, the existential crisis that is jaundice? What is our clinical approach to jaundice in the emergency department? We're gonna make it very practical. And then at the end, ALiEM has a very special residency competition. So you're gonna go from your isolated homes, looking at your laptops, you're gonna go to your program channel, and you're gonna work together for 5 minutes on a challenge instead of doing Q&A with me. All right, so let's start. So what is jaundice? I like to define terms when I'm lecturing. If anyone's ever been to one of my clinical lectures, I always stop and define the term. So what is jaundice? Jaundice is the yellowing of the sclera, skin, and mucous membranes with pigments that come from bilirubin. And the higher your serum bilirubin, the more pigments will be deposited in these different areas. Now, jaundice and icterus are actually different words. Icterus is the state of lots of pigment, and the pigment being taken up by these structures, sclera, skin, and mucous membranes, is actually jaundice. Operationally, they're the same thing. It occurs because we have lots of bilirubin in our blood, and we're going to talk about the reasons that we get states of hyperbilirubinemia. Here's a little bit of jaundice trivia for you, because I know you're all dying for this at 8:45 in the morning on the West Coast. Jaundice is first noticeable at a hemoglobin, or a bilirubin level, total bili level of 2 to 2.5. And it's more noticeable in patients who are light-skinned. So I love this picture because it shows a patient who has probably a very high total bili, but because of his dark skin, you don't necessarily notice it on his skin until he opens his mouth and you look at his mucous membranes. So why do mucous membranes, skin, and sclera pick up the yellow pigment? It's because they have a lot of elastin. So bilirubin's pigments bind to elastin, and areas of your body that have a high concentration of elastin are more likely to turn yellow first. So the part of your body that is the most is the frenulum of the tongue. So look there before you look at the eyes if you're suspecting jaundice. And then, just like we said, it's easier to see in light-skinned individuals. It's even easier if you're anemic. So anemic patients who have light skin will become very icteric at lower levels of total bili. So what does this mean, right? I defined a term, I've given you some trivia, but what is the clinical application of jaundice? When you see a jaundice patient, what do you think when you walk down the hallway? Let's imagine we're not in the COVID crisis. I'm walking down the hallway, mask-free. I'm holding my coffee that I planned not to put down the entire shift. I see someone brought in on an ambulance stretcher who has obvious icterus. What am I thinking as the attending? So it's a state of hyperbilirubinemia. You have to think about what is causing a high total bili in your blood. And it's not always liver failure, right? So you might see that patient coming down the hallway on a stretcher, and you might think, oh gosh, I have another liver patient. But that's not always the case. So liver failure is obviously a very, very common cause of jaundice when we see these folks in the emergency department, but there are a lot of other causes that you have to think about as an emergency physician. So this brings me to Gisondi's 4 truths. There's another 4 truths about bilirubin. And faculty, you can unmute yourself for this because I've always wanted to be a small town preacher and tell the truths. So I'm going to say for every truth, you watching at home need to give me an amen in your apartment. Are you ready? Bilirubin is made. The first truth. Can I get an amen? Michelle, give me an amen. Amen.
Yes.
All right. Bilirubin is taken up by the liver. Give me an amen.
Preach.
Yeah. Truth. Yes. Amen.
Truth.
Bilirubin is conjugated. It's conjugated.
What?
Give me an amen.
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 And bilirubin
Yeah.
is excreted. Can I get an amen?
Of course.
Oh yeah.
Of course.
Amen.
It's not an of course, it's an amen. Small town preacher. All right. So these are Gisandi's 4 truths about bilirubin. This is how bilirubin builds up in your blood if any of those 4 processes are deranged. And I'll talk about that. Now, this very pixelated schematic I've had in my slide deck since I've been teaching about jaundice for 20 years, and I love it. I can't attribute the picture to anyone, but I think it's really helpful. So if you can see the cursor over here on the left is a capillary. In the middle, the big box is a hepatocyte, and the orange is a canaliculus in the hepatobiliary tree. And this is normal. This is a normal amount of unconjugated bilirubin being taken up by the liver cell, the hepatocyte, being conjugated by the endoplasmic reticulum in the hepatocyte, and being excreted in the hepatobiliary system. Normal amount. So before we get into what's abnormal, I do want to give you one other definition, and that's the Vandenberg reaction. The Vandenberg reaction is how you measure direct and indirect bilirubin in the blood. So sometimes we think about unconjugated bilirubin is the same as indirect and conjugated is direct, but that's not actually true. There is no sort of direct bilirubin. Direct bilirubin is the amount of bilirubin that reacts in an assay in the lab called the Vandenberg reaction. And it's measuring just direct bilirubin. And the normal percent of direct bilirubin in comparison to total bilirubin is 70%. So if that number drops, you can start to imagine that there's prehepatic causes of hyperbilirubinemia. There's probably more unconjugated bilirubin, but it's not a direct measure of the conjugated serum bilirubin. I hope that makes sense. The higher this number goes, the more likely that the liver is conjugating. It's taking up bilirubin and conjugating it. It's just not excreting it properly. So it's important to think about the differences between those words as you think through the lab values with the conditions that I'm going to talk about. So I'm always a pragmatist. I like things to be very practical. So if I take Gisandi's 4 truths about bilirubin, I'm going to take the same 4 truths about how hyperbilirubinemia becomes a problem, a clinical problem. So the first way we can get elevated bilirubin in the serum, too much bilirubin is made. So perhaps we're destroying too many red blood cells. They're releasing hemoglobin. The breakdown product of hemoglobin is bilirubin, and we're having an overproduction of unconjugated bilirubin. Bilirubin might not be able to be taken up by a hepatocyte. It might not be adequately conjugated in that hepatocyte if the hepatocytes are dysfunctional from acute liver failure. Or perhaps bilirubin just simply isn't being excreted. There's a surgically correctable obstruction in the hepatobiliary tree. So here's similar schematics. You can see this is a state of overproduction of bilirubin. So lots and lots of bilirubin in the capillaries. Perhaps we're at an acute hemolytic crisis. Some of that remains unconjugated because the liver cells simply can't pick up all of the increased amount of serum bilirubin. Some of it gets brought into the cells. The cells are working, so they're putting out that same increased amount of bilirubin conjugated, and it's being excreted very easily. Here's an example of a time where either the hepatocytes aren't taking up bilirubin, but the bilirubin is at a normal serum level, or they're not conjugating it, right? So eventually you're going to have an increase in unconjugated bilirubin in the blood. So you're going to have a decrease in that percent number, the total versus direct bilirubin. So it's just not getting conjugated, and certainly it's not being excreted. And in the final image, we have normal amount of bilirubin being taken up by normal hepatocytes that are conjugating normally, but there's a surgically correctable cause of obstruction that needs to be relieved in order to excrete properly the high now building up of the serum bilirubin. All right, so if you're a hepatologist, you think through classifications of hyperbilirubinemia in a bunch of different ways. You may think of unconjugated versus conjugated differentials. You may create your differentials in your mind as prehepatic, hepatic, posthepatic. They make a lot of sense to me. But I think about classifications as an emergency physician. The way that I classify hyperbilirubinemic states is by threats to life. So there's really 4 questions that you have to ask yourself when you see a patient that has jaundice. First, is this an acute hemolytic crisis for which I need to begin emergent plasmapheresis? Is there acute liver failure? Did your patient 48 hours ago try to commit suicide by drinking a bottle of acetaminophen, and now they need an emergent liver transplant? Is there a surgically correctable cause of biliary obstruction that if they go to the OR, this is going to relieve that obstruction and and allow excretion of the bilirubin. Or if this is an infant, is this neonatal jaundice, a newborn who's yellow, certainly has a very, very high risk of kernicterus and brain damage, if not death. So this is a very brief lecture. Michelle told me to keep it short. I'm not going to be able to cover everything you need to know for that ABEM in-training exam. By the way, shout out to ABEM for sponsoring today's ALiEM Connect. There are some other topics that you guys are going to need to read about on your own. One is neonatal jaundice. Neonatal jaundice is its own lecture entirely. I'm not going to cover any of the details about that, but it's a very, very important condition. I also don't teach about eponyms. So all of these names are associated somehow with the liver, and they're going to all be foils on that ABEM in-training exam. They're never the answer, never pick them. But you need to know what they are so that you know that they're the foils so that you don't pick them. So read about those names. All right, so in summary, there are 4 truths about bilirubin. If you existentially know that bilirubin is made, bilirubin is taken up by the liver, bilirubin is conjugated, and bilirubin is excreted, you can think through the differential of pathophysiologic states about hyperbilirubinemia. And that's going to bring us to our ALiEM residency challenge. So instead of a Q&A, we want to take the next 5 minutes for you to go to your program channel, and I want you to create a differential for hyperbilirubinemia. I didn't talk about the actual conditions. I just helped you classify it in your mind. So the program that comes up with the most robust and comprehensive differential for hyperbilirubinemia is going to win an amazing prize from ALiEM. So we'll take that break and we'll be back in 5 minutes.
Thanks so much, Mike. The Church of Gisondi has spoken, and we have
Amen.
5 minutes. Amen. I am curious what this mystery prize is, because Gisondi said he wouldn't tell me, but I am game for giving out whatever he wants to give out.
Oh yeah,
Well,
it's going to cost.
I'm a little scared, actually. I should have given him some restrictions. But go ahead and start.
Once the residency program comes up with their comprehensive list, somebody in the residency program has to put it together in a single text or PDF or something and send it to me via Slack, and I'll make the determination who wins.
All right. And the deadline for that, Mike, when do you want it in by?
By the end of the hours. Yeah, by the end of ALiEM Connect.
Okay. All right. So let's meet back again in 5 minutes past the hour, whichever time zone you're in. That's 9:05 on the West Coast and 12:05 on the East Coast. See you in a bit.
So this is a friendly reminder. You have about a minute left, so start wrapping up.
All right. I think we're going to get back together here after you're in your program channels talking about the differential diagnosis. I can't wait to see the list, and I can't wait to hear what the prize is as well, which will be to be determined. So we are coming back from break now, and let's just keep going. We're on such a momentum, and wow, we are really lucky to have on the next speaker with us, Dr. Adaira Landry. What? She is the assistant program director at Harvard Hamer program and also the ultrasound fellowship director at Brigham and Women's. And she is here to talk about mentorship. It's something, people talk about and they give a lot of flack about, but like, what is it? And she's here to talk about mentorship as a journey and beyond. So welcome to ALiEM Connect, the Sapphire Shield.
Oh, that's nice.
Yeah, I thought that was a nice one. That's one of my favorite ones.
I'm really excited to be here. Thank you so much, Michelle, for inviting me. Just to preface my lecture, I've been quarantined for like the last week or so, and I've spent an extraordinary amount of time with my toddler. So my lens right now, as far as what the world looks like, is toys and arts and crafts, cartoons and puzzle pieces. So I apologize in advance that you're going to see a lot of cartoons through my lecture. That's just how I see the world these days. So let's go ahead and blast off. Oh, how do I advance these slides? Hold on. Here we go. All right. So the title of my lecture is Mentorship, a Journey and Beyond. I'm hoping to give you guys tips on how to improve your experiences with mentorship, and I'm going to use that wastebasket term just for all types of support that you can get from faculty members. But I will sort of delineate a little bit about the different types of support you can get. I want to start off by saying mentorship is hard. Just in general, relationships as an adult are hard to maintain and hard to acquire. People are busy. A lot of mentorship is unpaid, unprotected work. So it's a little bit tricky to sustain those relationships. It's also hard to manage up. It's hard to ask someone to meet a deadline for a letter of rec, to finish their part of a paper. It's hard to get them to pick up a phone call sometimes on your behalf. So I just want to normalize the fact that mentorship is hard before I give you all of these tips. I also want to normalize the feeling that you might feel like you need more mentors and that the people you have right now currently are not enough. And that you need more to your team. That's a normal feeling as well. I will say, for me, I didn't have my first mentor until I was a intern at NYU. I found someone by the name of Uche Blackstock, Dr. Uche Blackstock, who's amazing. And she was phenomenal to me because she was a rare breed. She was a Black woman in emergency medicine who came to me and shared her experiences. She shared all of her successes in a way that I felt like she was giving me tips so that her strengths can become mine. I also felt that she shared her lessons with me so that I would learn from her mistakes. She really showed me what support looked like. And because of her, I started to recognize what mentorship is and what it isn't. And there's different types of relationships that you can have in the workplace. So there's advising, which is generally more targeted contact with someone. So you might ask someone, should I take step 3 at this point or that point? It's not necessarily a deep, long relationship with someone. It's usually short-term targeted questions that might be asked. Mentorship, for instance, is a two-way street. There's a depth to it. It can be long-lasting, where it extends beyond, let's say, residency or medical school. It has that level of connectivity that is a little bit different than advising. And what we're starting to hear more about, I think, just in literature or even like, Harvard Business Review, they're talking a lot more about sponsorship. So a sponsor is someone who looks at you and says, oh my God, I need to get you to where I am. I need to make sure I'm nominating you for things. I'm in a meeting and someone says, who should we have take this opportunity? And that person is mentioning your name. Their role is really just to try to escalate your career. And they may or may not have a longitudinal, in-depth relationship with you. They might not talk about your family with you like a mentor would. They might not talk to you about anything else beyond just the escalation of your career. And that's okay. And that is a great place to have, a great person to have. The last thing is coaching. So a coach might just fine tune some skills, like, how can I better help you interpret EKGs or interact with nurses on shift, or what's better email etiquette that you can use. So it's a little bit more fine-tuned refinement. So when I meet with a medical student, the first thing or resident, the first thing I try to do is just tell them to first understand what galaxy they're in before you start deep diving into opportunities and people to meet. Just what is the lay of the land? And that can be, interpreted in a way of understanding the structure of the people who work around you. Who's in charge? Who's pushing buttons? Who's in charge of the finance? Who's in charge of operations? Just understanding the people and the structure is like so valuable for your career. And then after that, what are the values of the broader community? Like, what is your department? What is your larger group trying to achieve? The last thing is, what is the mission of your team? So, your smaller group of people who you're working with on a day-to-day basis, what are they trying to achieve? And so, sorry, my little toddler just walked in here, but she did not say anything, so that's great. So I say that because often when people are starting, medical school or residency or fellowship, they want to just sort of suck themselves into a project right away. And I get that impulse to really want to grab something and to really attach yourself to a project. But remember, the value in the beginning is people over projects, connections over commitments. Most of the time, you will find that when you're listening to sort of mentorship lectures, they'll ask you in the beginning to identify your needs. And I think that's that is a great option, to just list off all the things that you need. I would say in the beginning, when you're starting on an opportunity, is, to me, to find what success will look like and to find that early. So if you're finishing up your 3rd year of residency or your 1st year of fellowship, and you're thinking about this next year, like what will make this successful for me? How am I going to look back at the end of this year and say, oh my God, I achieved my goals? What are those goals? And I think once you have understood your objective for this opportunity and how that's going to be successful, then I think you can go back and say, who are the people I need to get there? For instance, when I started residency, I'll say residency, I wanted to create a project for wellness for residents. And so my goal was to create this, group therapy project for residents. And I needed to go back and find people who did that. And so it was just an easier option for me to say, this residency experience will be successful if I have implemented a way that makes my residents feel more well. And then I found people who I felt like were within that frame. Excuse me. So once you've identified an opportunity itself, and you've established once you have identified the landscape of where you work and you have identified what success looks like, then I think you are ready to pick an opportunity. And when it comes to picking an opportunity, I always say, pick a project that pushes boundaries, or pick a mentor who pushes you. You definitely don't need both, but you absolutely need one. Otherwise, you might be picking projects that aren't really innovative, that aren't new, they aren't original, or you might pick mentors who just aren't around. And I think that itself will put you in a position where maybe you're not really advancing yourself in your career. So those are sort of my big 3 theories regarding mentorship. I'm going to kind of dive deeper into some action items that hopefully you can take. The first is a mindset change. So a lot of us, myself included, I'll be quite honest, myself included, we wait. We just have so much potential energy, and we're just waiting for someone to tap into it, right? So we're at the top of this, I don't know, moon. And I drew these, and okay, so we're at the top of this moon, and we are just keeping all of this potential energy within us. And we're waiting for someone to say, Adaira, why haven't you applied for this? Michelle, you should go for this. People are busy. People do not have the time to do that. So you really have to change your mindset and take ownership and go from potential energy to kinetic. My husband's an electrical engineer, so he is laughing right now about how I'm describing potential and kinetic energy. But what I'm saying is, don't just hold it, but use your potential energy and make it kinetic, okay? So you have to stop waiting for people to come to you and knock on your door and say, hey, I just got this opportunity that came to my desk. You should do it. Feel comfortable asking someone else about this opportunity, about this, this position, and say, hey, I'm really interested in this. I'm wondering if I could have your support. I'll tell you that when I became a junior faculty member at Brigham, everyone around me, it seemed like everyone was getting opportunities. My chair was, he sent out these weekly emails and saying, someone else got promoted, someone else got this grant. And I was just like, how are people doing this? And it wasn't until I met with, one of my mentors here now, Valerie Dobias, who basically said, hey, you have to go for it. Like, you really have to chime into your own career, and you just can't sit there. Okay. And you have to also say, you deserve this. I deserve this. I deserve to share my potential with other folks. Okay. So who are the other folks that you're going to put on your team? So, you got to make your own inclusion and exclusion criteria for this. There are different strategies. Okay. You can go for the big names, right? You can say, I'm going to go for the department chair. I want that person to be my main mentor. But you have to just understand that that person is going to be very busy, and they're probably not going to have the time to do weekly or monthly 2-hour meetings with you. But they still have their value as well. For instance, I went to my chair a couple of weeks ago and I said, hey, months ago, and I said, I think I need more mentorship from people who are actually outside of medicine, who are senior and who are women. I asked him specifically for that. So he found me someone who was the president of a local university here. I met with this person, but we only had like a 25-minute meeting. And I asked this person, this lady, this woman, one specific question, right? I didn't go to her with, a vague plan or anything like that. I said, what should I do about this? And she was able to talk to me about that. So I think those big names, those people who are very, very, very busy, they have their value. But I also think folks who aren't maybe in like the top positions in your department or in your institution have a lot of value. They have more time. They might not have as much experience, but they can workshop things with you. So creating that team of people and thinking about having some balance between not just the higher ups, but also some who are also working their way up as well will be valuable for you. I really encourage you to go outside of your department, outside of your institution, outside of your city. Michelle Lynn here was one of my first mentors, and Mike Gisondi, who were outside of my, they're in California, they're in sunny California mentoring me while I was buried in snow in New York City. And we never even met in person. I think for the first year or so, we hadn't even really met, maybe 6 months, we hadn't even met in person, and they were giving me so much valuable experience. And so not being afraid of finding someone outside of your local domain is super important. The other thing is, after you meet with someone, it's really great to go, if that one person's your meteor, you want them to find you like a meteor shower. So you want them to give you more names. So I usually end meetings with, who are 3 more people I should meet with? Give me more names. And you don't have to meet with all of them, right? They might not meet all of your inclusion criteria, but just having that name will help snowball into more and more folks that you can meet, right? Now, the last thing is to diversify your team. Like, I love having women mentors. I love having women mentor of color. I love having men. I love having everyone. One thing I tell my resident is that a lot of my residents who work with me on projects, after they worked with me a few times, I try to push them out. And not because I'm tired or busy, those are true things too, but because they need to grow from where I have left them. And so they can fine tune the growth skills that I've given them by finding more mentors, finding more people to collaborate with. So don't forget to sort of expand beyond your comfort zone and find folks outside of your little small network. Here's the secret sauce, okay? Recognizing a wormhole. This is someone who will start where you are, like you start where you are right now, and they just like put you in another place really quickly, really easily. Michelle Lynn for me was my wormhole, and she is my wormhole. And she has helped me get so many opportunities that have accelerated my career in a way that I think would not have been possible. Now, this is like the most rare breed of support that I think you can find. So don't put pressure on yourself to find that right away, but being able to, recognize when someone says, hey, I have this opportunity for you. For instance, this lecture, Michelle asked me to give, and I was like, I'm not gonna give it. There are people who can do this much better than I can.
True story.
True story.
It was. I voluntold her to do this.
And I said, no, I'm not going to do it. You know, I'm junior, I'm busy, I have 2 toddlers at home. But Michelle's like, no, you need to get yourself out there and really just like push. So recognizing,
just put her on the website. I'm like, Adaira Landry, period.
So finding someone like that, it's really helpful for your career, right? And then the last thing I want to say is keeping communication tight. This is probably, from an operational standpoint, one of the most important things. Is to be engaged. And that kind of goes back from the potential energy to kinetic energy with keeping that communication as tight as possible. So you have to set up the meetings. That means a calendar invite. One of the things that Dr. Uche Blackstock told me is if it's not on my calendar, the meeting does not exist. So making sure that they have, an Outlook invitation set up, you create the agendas, you ask specific questions, right? The specific questions thing is key because it's really easy for me to find your inner star if you give me a telescope. And so I can really understand where you need to go if I have some information. The last thing is don't be afraid to use multimedia. So FaceTime, Slack, Zoom call, everything needs to be appropriate for the type of conversation, right? I wouldn't text someone about something that's really, really sensitive that I need to sit in person with and have a long period of time. But you can use, different types of mediums to connect with people. And then lastly, after you have met with them, send a follow-up. Send a follow-up email, set up your next appointment, but keep that communication tight. And again, not waiting for someone to reach out to you is super, super key. Excuse me. Okay. So it all can't be great, right? Like mentorship is not all easy. It's not all super polished. And there can be days and experiences and moments where you're like, this isn't working. And so be wary of even well-intentioned or bad-intentioned, but black holes. And that is, people or projects where you're just putting in a lot of energy and it's just getting sucked out and nothing else is coming out. Nothing is able to escape. And I think that was really tough. That was a tough lesson for me to learn, where if you feel like your career or an experience with someone is not really productive the way you had initially assigned it to be or thought it would be, and the way you described success earlier on, you're not finding that being matched, it's okay to reassess, to check in with someone and say, hey, I feel like I'm not able to actually show my work. Nothing's really coming out of this. And I think actually Shuhan, he was the one who said, fail fast. And it's okay to sort of drop something. It really is. And it's okay to drop someone, but do it with grace and do it, with moderation, right? And you can keep a relationship as a fine line, and not necessarily cut it completely and minimize some of that awkwardness afterwards. So that's my lecture. I want you all to hopefully find your path and destination as you journey through the skies and beyond.
That is amazing. LA, anyone got some questions for Adaira? You're on mute. I can read lips, kind of.
I can't hear that.
Yeah. Well, while he's trying to unmute himself, I do have a question for you, though, which is what is in your mug? Because I regret not getting coffee before I started.
Yeah.
Oh,
We were
it is-
debating on the Zoom channel. I'm like, is she drinking scotch? What is she drinking?
no, so I have been having a cough and a sore throat, so just tea. Yeah, there's nothing crazy.
Adaira, quick question. So can you talk more about sponsorship?
Yeah, just in general. So, you know, I like to think of sponsorship as a person who is a really solid advocate for you, and they see an opportunity and they are willing to do whatever it takes for you to get there. And that might be writing a letter of recommendation, making a phone call, sending an email, but they're willing to sort of help get you from where you are to the next level.
Thank you for that. For newer trainees or learners, it's somewhat intimidating to find a new mentor. How do you approach? What is your approach to finding that new mentor? And any rules on the roads to ensure that you're at a good start?
Yeah, so you know, I think most places, like at least for residency, and I know many med schools, like you're sort of assigned someone when you come on. I was assigned a mentor when I started. I think that is a good, you know, even if the person is not doing exactly what you want to do, or they're not completely in line with who you are as a person, it's still good practice to just being able to communicate your thoughts and your needs with someone. So I think that's a great first step. The second thing would be finding out what your interests are and figuring out who are the thought leaders in that area. So this sort of goes back to expanding beyond just where you are right now. I've encouraged residents, med students, my fellow to, you know, move beyond just the local area if you can't find someone within your small little region who's doing exactly what you want to do. So if someone's, you know, they wrote a paper and they're in Seattle, Washington, for instance, like you can reach out to them and just set up a quick meeting. Most people are willing to meet at least once and connect with them and ask them questions and see if you can build that relationship. And again, building that relationship sort of goes back to what I was saying earlier with keeping the communication tight.
Any advice for residents with multiple interests and difficulty identifying one and identifying what success means?
Yeah, I mean, I think that is like the $1 million question of, I mean, I am someone who, you know, so I have an interest in ultrasound and education and diversity and inclusion. And, you know, I would say generally people will say yes to everything. And I say that with an asterisk. I would say if you're early on, I think that's okay, but I think you're better off if you use that two-tiered approach, which is the person you're working with is really amazing, or the project you're working with is really amazing. Because in both scenarios, even if you have just one, you're going to become a better person when you come out. And so I think, you know, continuing to add on those opportunities is fine because you're going to learn some skill set. And then as you mature yourself, things will start to fall off. All those side interests will likely fall off and you'll focus. So I think it's okay if you're super when you're junior to say yes to things, but I would still make sure that they uphold to that. The people you're working with are great or the project is great.
Thank you. Lots of pearls here. I was tweeting and typing and all of these things together. So thank you so much.
Awesome. And maybe if Adaira, you could look back in your Slack channel, they're just like the questions just keep rolling and I wish we could ask all of them, but these are wonderful pearls to have. And I'm super excited that we got to join you in your astronomical journey. Wormhole, I do like that term. I'm going to use it maybe as part of my superhero name. I might try to incorporate that. But Sapphire Shield is well named for you. That's perfect. Let's transition though in the sake of time. Let's try to end on time here, which is with Dr. Bryan Hayes on the topic of boxed warnings for ED drugs and what are the risks. Now, you know Bryan Hayes, he's been on the ALiEM team like forever, for many, many years. And he talks about all things that are so salient to what we deal with and everything related to drugs and things with side effects. He's amazing, a wealth of resource. I kind of wish I had him on shift with me every shift. He's an assistant professor of emergency medicine at Harvard and the ED pharmacist over at Massachusetts General. And he appropriately is superhero named Electron Master. Welcome to Connect.
Thank you, Michelle. We're going to jump right in just so that we can stay on time and get you out by 1 o'clock Eastern time. Before we do that, though, I want to let you know about the resource that goes along with this talk. So this is my website, PharmER Talks Guy, and I have a link for lecture handouts and recordings, and the lecture notes for this talk today are right here. And they have links to all of the references we're going to talk about today. So you don't have to take notes. You can go back to this later on and read all about the stuff we're going to talk about today. So we're going to jump right in here. The FDA is having a lot of problems right now. They're under a lot of stress with all this COVID stuff and the new drugs. But one of the things that they do is they apply boxed warnings to drugs that they think have problems with them. And we used to term this the black box, but it's now just a boxed warning. And this is a little bit different than a contraindication. This is when they deem that there's a serious or life-threatening risk that goes along with a given drug. So we're going to talk about a couple today that we use a lot in the ED and talk about whether the risk is justified or whether it's something that we can relatively ignore. The reason it gets the black box name is because it literally is a black box that sits on the drug label. So there's no rhyme or reason other than this is a black box, and here it is. This is one for fluoroquinolones, which is one of my least favorite classes of drugs and one we will talk about in just a few minutes. The reason I think this is important to talk about is because many of us don't consider black boxed warnings when we are writing prescriptions or ordering meds in the ED. Less than 40% of us do. So this is something that I think should be a little bit more on the forefront for some specific drugs that we're going to mention today. The first group is fluoroquinolones. Everyone knows about the tendon rupture risk. And compared to other antibiotics, the risk is 4 times higher. And if you are an elderly person and on steroids, the risk is 43 times higher. And this is largely related to Achilles, but this could be other tendons as well. So this is a serious one. And if we put this into perspective of number needed to harm, this is 1 in every 6,000 patients that gets a prescription for fluoroquinolones will end up with an Achilles rupture. And if you're on steroids, it's 1 in 4,000. So individually, we may not write for a ton of fluoroquinolones, but think about your department and think about a whole hospital that's writing outpatient prescriptions when patients leave the hospital. 1 in 4,000 or 1 in 6,000 becomes very much a reality relatively quickly. So keep this in mind when you're thinking about antibiotics for your patients. I'll never forget back when I was a first-year pharmacy resident in one of the ICUs, we had this elderly patient who was in the ICU for a couple of days. And over time, her renal function had started to decline. And all of a sudden, she started having seizures, which she'd never had before in her lifetime. And it turned out to be related to the levofloxacin that she was on. As it started to accumulate with her kidney injury, she started to have seizures, which was a problem. Neuropsychiatric effects are also part of the black box warning with CNS other symptoms for fluoroquinolones. So that's 2. We have tendon rupture, we have seizures and neuropsychiatric side effects. We have myasthenia gravis. We know that all antibiotics can somewhat cause or exacerbate myasthenia gravis, but fluoroquinolones are at the top of the list. So if you're thinking of one class of antibiotics to absolutely not prescribe to these patients, it is fluoroquinolones. And the last official boxed warning is peripheral neuropathy, and the relative risk is about double. And the concerning thing about this is that this effect can last even after the drug is gone. And some case reports have actually suggested that it's permanent. So this is an effect that could last forever with some patients. And if the 4 box warnings weren't enough, these are some of the other horrible effects that go along with fluoroquinolones. And each one of these has a small individual risk. But when you take this in context with the boxed warnings, there's
Brian,
a lot going. Yes.
Hey, sorry to interrupt you. I don't think we're seeing your slides. You're saying there are 4 other meds. I think we're looking at your handout right now.
You are? Oh my gosh, I'm so sorry.
No worries. Sorry to interrupt, but I figured we're missing some good stuff.
You are indeed.
Yeah, I know.
Let me stop sharing and I'll try and share again. Hold on here.
Cool.
Sorry about that. Thanks for stopping me. That's too bad. I had some great slides that we all missed.
Oh, we can upload some onto the, we can upload later.
Them all. Sorry for that, everybody. So when you take into account the 4 boxed warnings along with the other effects of fluoroquinolones, there's just a lot to consider. Drug interactions is another one. So overall, where I think that we should relegate these 2 is similar to what the FDA said last year. And they said only use these medications if there are no alternatives. They only pointed out these 3 specific conditions, but I would apply this to everything that you'd consider a fluoroquinolone for. This should be your 2nd or 3rd line therapy, not your 1st line therapy. So my overall verdict on fluoroquinolones is that we should not be using them in the ED if we can at all avoid it, unless there is no alternative to give. Second, if you're on social media, you have certainly seen the hate towards tramadol. It's out there for sure. And it has 8 boxed warnings, this drug, 8 of them. And the reason that I think this is important is we think of tramadol as a safe alternative to opioids, but it really isn't that, because it is an opioid. And as you not be surprised by, many of the boxed warnings are exactly the same type of things you would be concerned about with opioids: respiratory depression, abuse dependence withdrawal, neonatal abstinence syndrome. All of these things are associated with tramadol and contribute to its boxed warnings. The other thing with tramadol is it's kind of messy. It doesn't just act like an opioid. So if we give it to patients, everyone's not going to have the same effect from it. Some are going to have an okay effect, some are going to have no effect, and some are going to have a really exaggerated effect, all dependent on the metabolism. And we're all different, and we can't really predict it. So if 3 different of us speakers could take a dose of tramadol, and all of us might experience a different effect from that, and that's problematic. The other piece is it's also a serotonin norepinephrine reuptake inhibitor. So if you want to give your patient an antidepressant, then give them an antidepressant. Don't give them tramadol as their drug. There's also seizures and hypoglycemia, and these lead to hospitalization. So I see a lot of patients with seizure disorders that get prescribed tramadol, and I worry for them. I remember back when I was at the University of Maryland, there was one day I came in and we were rounding in the ED, and 2 patients in a row in consecutive rooms, both were in for seizures related to the tramadol that they just got put on, even though they had a seizure disorder at baseline. So keep that in mind when you're thinking about tramadol as a potential pain management option. Does it even work? Well, there's a couple of Cochrane reviews about this, and they basically say that it's maybe modestly effective and comparable to alternatives, depending on which type of pain we're talking about. And when we compare it to other medications we use in the ED, like hydrocodone, acetaminophen, it's really not much better than it for ankle pain, and it's inferior to it for musculoskeletal pain. So it really doesn't work all that well. And I know some patients will swear by it, and that's okay. It may work for some, but for most, it really doesn't work all that well. So when I take into account the boxed warnings, the extra side effects of seizures and hypoglycemia, and the fact that it doesn't really work that well and it has the drug interactions and messy pharmacology, tramadol is on my list with fluoroquinolones as boxed warnings that we should be avoiding if at all possible. Just earlier, actually in 2019, we're already in 2020 now, droperidol, which is a drug that many of you probably have 0 experience with because it hasn't been on the market for almost 10 years because of a massive drug shortage, but it is back. And so you should know about it. And some of you may be getting it back in your EDs as we speak. It's used for a lot of different things, kind of similar to haloperidol. It's good for nausea and vomiting. It's good for cannabinoid hyperemesis syndrome, migraine headaches. It's really good for, and higher doses can be used for agitation, and it works really quickly. It actually is one of the quicker acting meds to control someone who's severely agitated, second only to ketamine. The reason that this has a boxed warning is the FDA basically has this open registry where you can submit adverse effects from drugs. They're not in the same way that in a case report would be peer journal. But they basically collect all these cases, and if they see signals, then they will issue statements or warnings or put boxed warnings on drugs. So this was 273 cases over 4 years where patients had cardiac events or death. Largely, they thought related to QT prolongation. This is the big concern with droperidol. But there were a couple of groups that looked really closely at these cases. They asked the FDA for them, and they said, okay, can I have these cases? Give me all the data you have. And they looked at them, and very few, if any, were actually related to the droperidol. There were a lot of other risks that these patients had for QT prolongation or torsade. So it's really tough to say that droperidol had anything to do with the adverse effect that the patient experienced. And somehow, during this 10-year period when none of us had droperidol, the Mayo Clinic had tons of droperidol. I'm not sure how this happened, but thank God they decided to publish on their experience over this last decade. and almost 7,000 patients got droperidol. And maybe they're part of the shortage. Maybe they're the reason. Anyway, they gave it for all the different things that we give it for: pain, sedation, nausea, headache. And they found 0 deaths and 0 dysrhythmias related to droperidol use. Now, retrospective review, definitely some limitations to this study that we don't have time to get into today. So I'd ask that you read that thoroughly. But a real life emergency department experience with droperidol, no adverse effects that we need to speak of. I'm pretty encouraged by these results. And I think it just adds to the fact that this is a drug that we should be using now that we have it back. Who should we be worried about and maybe get an EKG on? Patients with electrolyte disorders, magnesium, potassium, other QT prolonging meds, and we use a lot of them in the ED, cardiac risk factors, and increased age, kind of the normal things that you would think of for patients that might have QT prolongation risk. This is a statement that got put out by the American Academy of Emergency Medicine a couple of years ago, and I agree with this statement strongly. They said it's effective and safe, and they say that we don't even support the use of an EKG before giving doses that are less than 2.5 milligrams. And remember, most of the indications that we're going to be giving it for a couple slides ago were less than that dose, so we are okay to do this. And they say even doses up to 10, which is what we would use for agitation, also are safe and effective for those patients. So my verdict on droperidol is get this back in your EDs, get familiar with it before you graduate, and start using it as soon as you can. The other question that comes up, and this isn't really box warnings, but I think it's related, and it's something that we really encounter every day in the ED, is what about the other antiemetics? Which ones are safe to use for patients that might have risk factors or actually do have QT prolongation? So I want to just jump on a couple. The first one is metoclopramide. There is a really good site out there. It used to be called qtdrugs.org, and I think it changed its name to Credible Meds or something, where basically you can create a free account and you can go online and it gives you the data on how likely these drugs are to cause QT prolongation or torsade. And metoclopramide is probably the safest of all the antiemetics that we use in the ED in terms of QT prolongation. So this is one of my go-tos if I have a patient where I don't want to add anything more that would prolong their QT. Similarly, prochlorperazine, we have this one back now. This one is also great for migraine headaches. And this one also has minimal risk of QT prolongation. So metoclopramide and prochlorperazine are my go-tos. I wish I had a teacup like Adaira, but I just have an orange water cup instead. The last one I wanted to mention, because we use this literally hundreds of times a day throughout the hospital, is ondansetron. There's been a lot of talk about this drug and its ability to prolong the QT interval. And these are 2 studies that I wish I would have just done myself, but there were 2 studies that literally took ED patients that came in and they got an EKG, they gave them a 4 milligram dose of ondansetron, and then they measured their EKG again to measure how long the QT was prolonged. And they found that on average, 16 to 20 milliseconds was the prolongation. Not clinically significant in most cases. So that was a great study. There was a separate study, not in ED patients, that looked at patients with cardiovascular disease and QT prolonging risk factors. So this is kind of a higher risk population. And they found the exact same thing, about 20 milliseconds altogether. And there was a 4th study that looked at PD patients, and they found with a standard dose that there was really no QT prolongation at all in this population. So that's pretty encouraging. So where do I stand on all of this? Metoclopramide, definitely okay to give. Prochlorperazine, also okay to give. Remember too, that depending on your doses with those, you might want to add some diphenhydramine depending. And we have a good ALiEM post on that authored by our very own Michelle Lynn. And finally, for ondansetron, also safe to give in most cases. The only time that I would recommend an EKG first is if you're giving a repeat dose. So the first one didn't work. If the patient has QT risk factors at baseline, or if the patient is on or getting other QT prolonging meds like methadone, which is a really common one that a lot of our ET patients are on. So just to wrap up today, and I apologize for not having the slides for the first couple of slides, so we'll definitely get those posted for everyone. In my opinion, we should be avoiding fluoroquinolones unless there is no alternative. Tramadol also should be off our plate. The problem with tramadol is we're trying to avoid opioids too, so that doesn't leave us with a whole lot of oral options for pain meds. I like the use of acetaminophen. I like NSAIDs for the shortest possible duration and the lowest dose. I also like lidocaine patches and topical therapies. So there are other things that we can do, but tramadol, I would say, should not be on your list. Droperidol, use it. and get familiar with it. In terms of drugs for nausea, metoclopramide and prochlorperazine are okay. And ondansetron is also okay in almost all cases. Just get an EKG first in the patients that we mentioned that might be at a little bit higher risk or have some prolonged QT at baseline. And with that, I thank you for your attention. This has been great. I'm really glad to be a part of this. Thank you, Michelle.
LA, are there some questions you want to lob?
Yes. Let's see here. So there was a mention about there's no alternatives for bronchitis and pneumonia. What about diverticulitis? Like, do you have any suggestions about that if you're going to give ciproflagyl?
Yeah, ciproflagyl is one of the common. So I should preface by saying there is some newer data that says that we may not need to be treating all of these diverticulitis patients anyway with antibiotics. So make sure you're up to speed on that literature. I don't think ciprofloxacin flagyl is bad in patients that are younger, really don't have a ton of risk. However, I like the amoxicillin clavulanic acid, the Augmentin combination in place of Cipro. I think that adds a pretty good amount of anaerobic coverage as well. And if you need more, you can always add metronidazole on top of that.
Any thoughts about combining droperidol and benzodiazepine when you're sedating somebody?
Yeah, this is a question that comes up a lot. Droperidol, I will tell you, if you have experience with it, it actually works pretty quick and you don't actually need a benzodiazepine. Hi, Adaira's kid. We actually don't need a benzo most of the time. And the benzos actually work a lot slower. So if you give droperidol, you usually don't need the benzodiazepine to go along with it, unlike with haloperidol, which you usually do. So droperidol, you don't need it.
Switching to nausea treatments, thoughts about alcohol swabs?
Yes, they do not prolong a QT, and I highly recommend them. Also, we had a really good ALiEM post on that too, but we start using them in our ED, and the nurses love it. It's a really quick, easy intervention. They are not on shortage as far as I know, and at least lets you evaluate the patient and start to think about what therapies you might need. And some patients, honestly, that's all they need, and they don't need a dose of anything else, which is really good. So definitely.
There's some research recently apparently about Benadryl not as good as prophylaxis for akathisia. What are your thoughts on that?
Yeah, I would highly recommend that the group watching us out there reads the ALiEM post on that exact topic, because we delve into all the details. Where I stand on it now is if you're giving metoclopramide 20 milligram dose, which is what is recommended in a lot of the migraine headache trials, you should probably be giving it with a dose of diphenhydramine.
With that, let me just transition over in these last few minutes. I got just a few, actually just two tricks of the trade pearls for you, just to wrap up with the last talk. And let me work on this screen sharing with you and go from here. But, you know, in this COVID era, I tried to pick out my two favorite tricks of the trade that would help accelerate patient movement through your ED, because the last thing you want to do is have non-COVID patients just lingering about and potentially getting infected. So how do you get them out faster? And they deal with mainly two types of dislocations, right? They're not going to try to wait these at home because they really impact, you know, they're extremely painful and it impacts, in this case, eating. So mandibular dislocations, how do you reduce them? And the traditional teaching is, right, you basically bubble wrap your two thumbs and get this, you stick them into a patient's mouth, which may abruptly shut if you successfully do this reduction. That does not seem like a wise idea at all. But this is the traditional teaching for many, many years. And basically what you do is you traditionally push down on their occlusive surfaces of the teeth and then push hard, hard, hard. And you try to overcome the masseters and all the other mastication muscles up there and just try to force the condyle back into the TMJ, the temporal mandibular joint. Now that oftentimes requires sedation and even procedural sedation to get the patient relaxed enough. And that just takes up so much time and so much of your resources. And with the trick I'd like to propose, which is actually brought to my attention by Dr. Kara Tolles, and has gotten a lot of publicity about this, because I get all sorts of emails like, where have you been this whole time? It would have saved me 2 hours of stress. And this procedure takes literally 2 minutes, maybe even less. So how do you do this? It really revolves around your knowledge of the anatomy. So just look at the right image, and that's the one I'm going to focus on more, which is take a look at, I think I can use a pointer here. So here's the TMJ, trying to draw. Here is the condyle, anteriorly dislocated. And then here's the coronoid process. The coronoid is a part of the bone of the mandible that normally is tucked in just under the zygomatic arch. You're not going to palpate it normally, but when it's dislocated, it's going to pop out. So this is, this is TMJ, and this is the normal one, my bad. I'm going to look over here on the left side, and this is the dislocated one. So here we go. Here is the condyle, and then here's the coronoid. And now that it's dislocated, you can actually palpate it in the patient's face, just along their cheekbone. And so this is the point at which you want to push and lever the mandible back into place. So let's see what that looks like. Kara actually was able to consent a patient to have this procedure done on him. It's totally an amazing video. It's got a couple 100,000 views already. But what she's doing here is now the provider is taking full advantage of the fact that the mandible is a rigid structure. So you're just going to reduce one side at a time. Rather than pushing both down and clunking it in, it's going to be one and then the other. And you take advantage of the ring effect in that if you push on the patient's left mandible in this case, you actually hyper dislocate the other side. And so you're basically swiveling one side in, and oftentimes the second will pop back in on its own. So let's watch the video. I'm going to show it twice and we'll do a little bit of commentary. So the left side actually went in there. And in doing this, the left side popped back out, but the right side went in. And then a quick little nudge. And it pops right in. No sedation. Look at that happy guy. Yeah, there was much celebration after that. This is one of my favorite videos. But just to play it again, it really doesn't take much manipulation. You rotate the mandible to get one side in. And then you push on the other coronoid to get the other side in if needed. And if the other side pops out, just a little nudge.
I love the
right
smile.
In. It takes,
It,
look at that smile, right?
Yeah.
The high five at the end really gets me. The high five is one of my highlights. Oh, let's move on to the next one. We're doing okay on time, hopefully. Oh, yeah. So we have the second dislocation, which is the shoulder dislocation. There's so many people that love to talk about it, but really I am going to just talk about not the techniques, but really how do you get this person out of your ED with a successful reduction as quickly as possible, and especially in this COVID era. And sure, you can brute force it and just pop it in, but I think one thing that is not used as a first line is the intra-articular shoulder block, right? Most people, what they do is like, oh, shoulder dislocation, you're going to need an IV, and then you're going to do procedural sedation. They're going to need one-on-one nursing time, and then you're going to need them to wake up and then x-ray and then go. So what about this? Why don't you just, as your first line trial, just go ahead and inject intra-articular lidocaine. And in the meantime, you can start consenting them in case this doesn't work. But guess what? This works a lot of the times. And I think people are not having success with it because they are not using the right equipment. So let me just share with you, just to review the anterior shoulder dislocation. Here's the shoulder joint, and you have the proximal humeral head sitting on the glenoid rim. And when it pops out, you now have all of this potential space sitting under the acromion. And so the capsular joint edge is extremely exposed. Look at all that space. You can go here, 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 anywhere. That's all space for you to push lidocaine into. But then you're like, well, why are people missing this? I don't understand. Well, the issue is when you use a regular size needle on a syringe, you're really only getting as far as here. You're actually not getting far enough. And this has been proven on multiple ultrasound scans that people do before reducing these. Your needle is just not in that right space. So instead, if you're going to be doing this, and I advocate that you probably should as a first line, is to always use a spinal needle. Like don't wave this in front of the patient because that really freaks them out and they're not going to want to do it. But you should use a spinal needle and it always gets into the right space. Now, how do you know you're in the right space? I see some people start doing this and they're pushing like, I think it's kind of running. I'm not sure. And and then they try to draw back and they're like, I think I see a little blush of blood. No, this is a yes, no issue. It's like Murphy's sign. If you think it's a Murphy's, it's not a Murphy's. Murphy's is a positive or negative. Same thing with this. If you're going to get a flash of blood, it's like thinking about doing a femoral line. You get that flash of blood and you're in, kind of like this. You have a significant hemarthrosis with shoulder dislocations, and that is what you want to come into your syringe with the lidocaine before you instill all the lidocaine. And then how much do you push in? About 10 to 20 cc's. If the patient can tolerate the 20, that's ideal. and you put about the 1% lidocaine into the joint, again, after you get a blood flash return. So that's all I have. These are 2 pearls that I think can really speed up a patient's stay in your ED, and it involves mandible dislocations, extraoral technique, and the intra-articular shoulder dislocation block. All right, I'm going to hand it over to you if there are any questions. Probably not. Does anyone else actually have tricks on getting shoulder dislocations out of the ED faster, short of procedural sedation? That's what I want to know.
The intra-articular block is key, right? And the earlier you do it, the better.
Absolutely. The target audience, especially, I find, is like people with like a small muscle mass, or those who are older, elderly, and you just want to avoid the complications of procedural sedation. That is a great solution as well.
So far, no questions.
Oh, I like it because I'm that clear.
Answers about, do you have the final winner?
Yeah, guys, this is, I mean, mind blown. My Slack has been blowing up. So it's going to cost you double because I'm going to have 2 programs to win.
Oh, God.
That kind of guy.
No.
But I want to do my shout outs to UMass, Michigan, Arrowhead, Midwestern, Aventura, Rutgers, GW, Stanford, Madigan, UPMC, Pinnacle. All those lists were right on point. Shout out to Loma Linda, who said in their differential, highlighting the body with a yellow highlighter. Swedish Emergency Medicine said vampires. Outstanding. But our 2 winners, Michelle, are UC Irvine and Kendall Regional. You guys are going to get something at your first conference lunch when you guys return to in-person conferences. You have to send me an email and I'll make it happen. Congratulations, yeah. Irvine and Kendall.
That's amazing.
Amazing,
well, thanks
everybody.
Yeah, I can't wait to see what's in store. I'm a little bit afraid again. But just to maybe an extra few more seconds. Does anyone on the panel have last minute thoughts, questions, things they want to address that they heard earlier? I know Salim stayed all this time. I appreciate it. We were having a grand old time on our Zoom chat, so it was a fabulous time had by all. But thanks for everyone for participating. We hope that you had a valuable experience with this superhero panel of educators. And if you could do me 2 last favors, actually, this is a total big pivot in terms of what we do at ALiEM. That's the live conference idea, which always terrifies me, is we're asking for some feedback. And one is very short. If you go to the feedback channel of Slack, there are 2 simple questions and you vote by emojis. We don't like the Likert scare of 1 to 5. No, boo, we don't want that. We have tornado, partly cloudy. We have sunshine and rainbow. So you just kind of pick what you think about this program using that scale. Second is we're going to send a little bit more formal of a bigger survey, slightly bigger, just to get a sense of what your current or prior educational experiences have been, what it's like, and what role this hybrid format of a telecast and a Slack channel discussion has. Is it better? What parts are worse? What parts are basically replaceable, kind of the same? So we'd love to hear your feedback on this as we move forward in this kind of crazy, crazy era. Also, if you need extra conference time, you are actually on the aliemu.com site. So we have tons of asynchronous I3 credit stuff, including AIR and the capsule series run by Dr. Bryan Hayes himself. And lastly, I just want to give you guys a thank you and a shout out, kind of what Mike Gisondi had said. You guys are the bedrock. You guys are heroes yourselves. You guys and your families, might I say, working long hours, taking care of family, and taking care of the sickest patients in the community. So I think, instead of capes or frankly bandanas, heroes all wear N95 masks. So thank you and be safe out there. ALiEM Connect out.
Thanks, Michelle.
Thank you.